Your lungs are drowning from the inside. Fluid is pouring into the tiny air sacs where oxygen should be flowing, and every breath becomes a desperate fight for survival. This is acute pulmonary edema, and it can kill within hours. Today, we're diving deep into how hospitals use diuretics to literally pull life-threatening fluid out of patients' bodies, why some people's kidneys fight back against the very drugs trying to save them, and the breakthrough research that's changing how we treat the sickest patients. By the end of this episode, you'll understand the precise mechanisms that can mean the difference between life and death in critical care. Let me bring in someone who can walk us through this life or death science. Help me understand what's actually happening when someone's lungs start filling with fluid.
So picture this. According to the page content, acute pulmonary edema is characterized by the sudden onset of fluid accumulation in the alveolar spaces, which leads to compromised gas exchange and impaired oxygenation. What's terrifying is how fast this can deteriorate into life-threatening respiratory distress.
Wait, so we're talking about the actual air sacs in the lungs filling up with fluid?
Exactly. The pathophysiology involves increased pulmonary capillary hydrostatic pressure and permeability alterations of the pulmonary vasculature. The result is fluid leakage into the interstitial and alveolar spaces, leading to edema, impaired lung compliance, and hypoxemia.
And this isn't just from heart problems, right? The page content mentions other causes.
Right. While heart failure remains the most common cause, other underlying conditions, including acute kidney injury, trauma, and high-altitude pulmonary edema, can also precipitate this condition. But here's what's crucial. Regardless of the cause, the treatment approach centers on diuretics.
So diuretics are basically the main weapon against this fluid overload. But how do they actually work? Like, what's happening at the cellular level?
This is where it gets fascinating. The nephron, which is the kidney's functional unit, reabsorbs over 99% of the filtered water and solutes, primarily in the proximal tubule and loop of Henle. Different classes of diuretics target distinct nephron segments to interrupt sodium and water reabsorption.
99%? That's incredible. So the kidneys are basically recycling almost everything?
Exactly. And the fact that we can literally watch kidneys reabsorb 99% of filtered water and then precisely target different segments to interrupt that process, it's like having a molecular level remote control for the body's plumbing system.
That's such a cool way to think about it. So when doctors need to remove fluid fast, what's their go-to drug?
Loop diuretics, particularly furosemide, are the cornerstone of diuretic therapy in the intensive care unit due to their potency in inducing natriuresis and promoting fluid loss. They primarily act on the NKCC cotransporter in the thick ascending limb of the loop of Henle.
And this transporter, it's handling a significant amount of the kidney's work?
Absolutely. This transporter reabsorbs approximately 25 to 30% of filtered sodium. By blocking this transporter, sodium, potassium, and chloride reabsorption are inhibited, medullary hypertonicity is disrupted, impairing water reabsorption, and the net effect is increased sodium and water excretion.
So you're basically telling the kidneys to stop doing their job of holding on to water and salt.
Exactly. And according to current guidelines, the European Society of Cardiology, American College of Cardiology, and American Heart Association recommend IV furosemide as first-line therapy. Specifically 40 milligrams IV given slowly over 1-2 minutes.
But what happens when that standard dose isn't enough? I imagine some patients need more aggressive treatment.
That's where things get really intense. For patients with pulmonary edema complicated by hyponatremia and renal failure, the page content shows aggressive diuresis with high-dose loop diuretics up to furosemide 500 milligrams is the first-line treatment.
500 milligrams? That's more than 10 times the starting dose.
Right. And the protocol is to begin with high-dose loop diuretics, double the dose up to equivalent of furosemide 500 milligrams, with doses of 250 milligrams and above given by infusion over 4 hours. If there's no response to doubling the diuretic dose, they start IV infusion of dopamine at 2.5 e/Jacquard min.
So there's this whole escalation ladder. But what happens when even these high doses don't work?
That's when we hit what's called diuretic resistance. According to the research, diuretic resistance is defined as a failure to achieve the therapeutically desired reduction in edema despite a full dose of diuretic. And this is a major problem.
How major are we talking?
The page content indicates that diuretic resistance is a major cause of recurrent hospitalizations in patients with chronic heart failure and predicts death. More quantitatively, it's defined as a failure of oral furosemide 160 mg twice daily to increase sodium excretion by at least 90 mmol over 3 days.
So the paradox of diuretic resistance is that the sicker patients get, the more their kidneys fight back against the very treatment trying to save them. It's like the body's survival mechanisms working against itself.
That's such an insightful way to put it. The causes include poor adherence to drug therapy or dietary sodium restriction, pharmacokinetic issues, and compensatory increases in sodium reabsorption in nephron sites that are not blocked by the diuretic.
So the kidney is literally adapting to work around the drug?
Exactly. The research shows nephron mechanisms include tubular tolerance that can develop even during the time that the renal tubules are exposed to a single dose of diuretic, or enhanced reabsorption in the proximal tubule, or an adaptive increase in reabsorption in the downstream distal tubule and collecting ducts.
This sounds like an arms race between medicine and biology. So how do doctors fight back?
This is where some really exciting research comes in. There's been breakthrough work on combination therapy. The page content describes how diuretic resistance can be addressed by optimizing loop diuretic dose and by using combination therapy with other agents, including thiazides or thiazide-like diuretics or carbonic anhydrase inhibitors.
Carbonic anhydrase inhibitors, that sounds pretty specialized.
And here's where it gets really interesting. There was a major study on acetazolamide, a carbonic anhydrase inhibitor that reduces proximal tubular sodium reabsorption. What's fascinating is that acetazolamide, originally developed as an anticonvulsant, turned out to be this game changer for diuretic resistance.
Sometimes the best discoveries come from unexpected places. What did this study find?
The results were striking. In this multi-center, randomized placebo-controlled trial with 519 patients, successful decongestion occurred in 108 of 256 patients, that's 42.2%, in the acetazolamide group, compared to 79 of 259, 30.5% in the placebo group.
So adding acetazolamide improved success rates by about 12 percentage points?
Right, with a risk ratio of 1.46. And acetazolamide treatment was associated with higher cumulative urine output and natriuresis, findings consistent with better diuretic efficiency. This gives doctors a powerful new tool for the toughest cases.
But I'm guessing there are still cases where even combination therapy isn't enough?
Absolutely. When diuretic therapy fails completely, the page content shows that ultrafiltration or hemofiltration should be considered. In patients with severe renal dysfunction and refractory fluid retention, continuous venovenous hemofiltration should be considered.
So at that point, you're basically doing the kidney's job artificially.
Exactly. But here's something really important that often gets overlooked: the transition from IV to oral diuretics. This isn't just about convenience, it's actually a critical marker of whether a patient is stable enough to go home.
Really? I wouldn't have thought of that as such a big deal.
The guidelines are very specific about this. Intravenous diuretics should be switched to oral diuretics once clinical stability is achieved, typically indicated by resolution of volume overload symptoms, hemodynamic stability, and adequate urine output.
And there's a specific conversion ratio, right?
Yes, the switch typically involves converting from IV furosemide to oral furosemide at a ratio of approximately 1:2, so oral dose should be about twice the IV dose due to decreased bioavailability. For example, a patient receiving 40 mg IV furosemide twice daily might be transitioned to 80 mg oral furosemide twice daily.
So the oral version is less efficiently absorbed.
Exactly. The physiological basis for the dose adjustment is the incomplete intestinal absorption of oral loop diuretics compared to direct vascular delivery with IV administration. This transition facilitates hospital discharge and helps establish a sustainable outpatient regimen.
I'm starting to see how all these pieces fit together. But what about monitoring? These are powerful drugs we're talking about.
The monitoring is intensive. The page content emphasizes monitoring blood urea, nitrogen, creatinine, potassium, and sodium daily during IV therapy. And they warn that diuresis may be accompanied by worsening azotemia, especially if patients are also being treated with ACE inhibitors.
So you're constantly balancing removing fluid against potentially damaging the kidneys.
Exactly. And there's this interesting point about continuous infusion versus bolus dosing. The research shows that continuous infusion of furosemide seems to provide a higher and more stable tubular concentration of furosemide with respect to bolus injection.
So it's not just about the total dose, but how you deliver it.
Right. And despite evidence of any effect on mortality or on the need for renal replacement therapy, loop diuretics remain the most popular choice. The efficacy depends on tubular concentration, interaction with albumin, and addressing diuretic resistance.
Wait, did you say despite no evidence of mortality benefit? That seems counterintuitive.
That's one of the fascinating paradoxes in this field. The page content notes that most accepted pharmacologic treatments for heart failure are supported by evidence from large clinical trials, but evidence from large, well-controlled clinical trials to guide the use of diuretics is generally lacking.
So we're using these drugs because they clearly help with symptoms and fluid removal, even if we can't prove they help people live longer.
Exactly. Given the centrality of congestion to both symptoms and outcomes, diuretics remain cornerstones of management of heart failure. The immediate benefit in terms of breathing and comfort is undeniable, even if the long-term mortality data isn't there.
And I imagine in acute situations like pulmonary edema, you're not thinking about long-term mortality, you're thinking about the next few hours.
Absolutely. The page content emphasizes that early intervention and an evidence-based approach are essential to improving patient survival and minimizing complications. When someone's lungs are filling with fluid, rapid treatment with diuretics can be the difference between life and death.
Let's talk about some of the specific patient populations. The page content mentions acute kidney injury in cirrhosis patients. That seems like a particularly challenging situation.
It really is. Acute kidney injury occurs in up to 50% of hospitalized patients with cirrhosis, and in 58% of such patients in the intensive care unit. And it's associated with high morbidity and mortality, and an increased incidence of chronic kidney disease after liver transplantation.
So more than half of cirrhosis patients in the ICU develop kidney problems. That's a huge complication rate.
And what makes it complex is that hypoperfusion from hypovolemia accounts for approximately half the cases of AKI in patients with cirrhosis. Trinsic causes account for approximately 30% of cases, and hepatorenal syndrome accounts for approximately 15 to 20%.
So you have to figure out what type of kidney injury you're dealing with before you can treat it effectively.
Exactly. And this brings us back to the importance of individualized treatment. The page content emphasizes that therapy should be individualized according to patient response to gain maximal therapeutic response and to determine the minimal dose needed to maintain that response.
So when you step back from all this complexity, what are the key takeaways for understanding how diuretics save lives in critical care?
I think the most important insight is that diuretics work by precisely targeting different parts of the kidney's filtration system. By blocking specific transporters, doctors can force the kidneys to excrete excess fluid that's literally drowning patients from the inside.
And the fact that we can escalate from standard doses to these massive 500 milligrams doses, then add combination drugs, and finally move to mechanical filtration, it shows how many tools doctors have in this fight.
Right. But what's equally important is understanding that diuretic resistance isn't a failure, it's the body's natural response to illness. The kidneys are trying to hold on to fluid because they think the body needs it. Overcoming that requires sophisticated combination strategies.
And that transition from IV to oral diuretics isn't just a convenience thing, it's actually one of the most important markers of whether someone is stable enough to leave the hospital.
Exactly. When a patient can maintain their fluid balance on oral medications, it means their body has stabilized enough to manage at home. It's a crucial milestone in recovery.
Here's what really strikes me. We started with this terrifying image of lungs filling with fluid, and now we understand there's this whole sophisticated system of interventions that can literally pull that fluid out at the molecular level. The next time you hear about someone being treated for fluid overload, you'll know they're not just getting water pills, they're getting precisely targeted therapy that interrupts the kidney's normal function to save their life.